Before we get started, I just want to give a very good shout out to the organizer of this mega online anesthesiology course. Talking about Dr. Saad Mahdi, a very highly respected anesthesiologist, interventional intensive care specialist. He happened to be one of my mentors, and coming up as a trainee and resident in anesthesiology, he was there all the way. We want to thank him for bringing up this wonderful idea, even with all this era of COVID and this pandemic, these unanticipated conundrum happening, that we're able to, still get educated and get some CME, getting information from chronic pain management and anesthesiology as well. I want to thank Dr. Walid Aswa as well, and Dr. Imad for bringing up this idea. Today is going to be an all-packed presentation. We have two very prominent, eminent speakers in person of Dr. Mona Mubarak and Dr. Mohammed Yonis Makaritha. I'm going to be introducing the speakers in not too far distant time. The first topic of presentation today is going to be on chronic shoulder pain causes and treatment. We're going to be listening to Dr. Mona Mubarak, who is currently a consultant anesthetist and pain management specialist at the Galway Clinic. Interestingly, we trained together during our residency time. She did a pain fellowship at the Royal Alfred Hospital in 2015. She's trained in neuromodulation as a consultant at the Birmingham University in the United Kingdom. She had a special interest in pelvic and cancer pain. So today, with all honor and respect, introduced to us Dr. Mona Mubarak. I just want to let you know, we welcome everybody from Cairo to Egypt, to all the friends at Pain School International, and in Budapest, to the group in Harvard, in Hopkins, and to a wonderful group coming from the masterclass in West Africa, Nigeria, and all the people from the pain group as well, African Pain Group. We are all welcome. So without much ado, I will hand over the presentation to Dr. Mona Mubarak to blow us away. Thank you, Dr. Mubarak.
So, welcome everybody, and thanks very much for inviting me to present this lecture today. This is my second lecture in this great course. I really appreciate it, and I hope that you find this lecture to be useful and beneficial to everyone. My lecture today is not a long one. I actually did make sure that to be a short one to allow for some questions and answers at the end of the lecture, and because my colleague Dr. Makaritha will have a longer lecture for today as well. So my lecture today is about shoulder pain, causes and treatment. So I'm going to speak a little bit initially about the anatomy of shoulder pain and the biomechanics. It's very important to know about this because it will help us to understand more about what's going on and how to treat this problem. I'm just going to minimize this, so just give me a few seconds, please. So the shoulder girdle is composed of three bones, main bones: clavicle, scapula, and proximal humerus, and four articular surfaces, which are sternoclavicular joint, acromioclavicular joint, glenohumeral joint, and scapulothoracic joint. Now, regarding the glenohumeral joint, it's commonly referred as the shoulder joint, and it is the principal articulation of the shoulder. The glenohumeral structures is composed of the glenohumeral joint, which is constrained within a capsule bounded by the surrounding muscles and ligaments. The rotator cuff serves as the primary dynamic stabilizer for the shoulder. It's composed of main four muscles. They are supraspinatus, infraspinatus, subscapularis, and teres minor muscles. I just want to now touch base regarding the just give me a second. I just want to move actually this it's just hiding actually part of the presentation, so I'm trying to move this a little bit to the side. Okay, so the rotator cuff muscles, in fact, it rotates the humerus internally, which is the subscapularis muscle, and externally the infraspinatus muscle, primarily, and the teres minor. And it contributes to the abduction supraspinatus muscle along with the deltoid muscle. The suprascapular nerve, it innervates the supraspinatus and the infraspinatus muscles mainly. It can cause actually peripheral neuropathy in 1 to 2% of the pathological shoulder conditions. There is as well extra glenohumeral structures, and this is actually, in fact, can participate significantly to the shoulder pain problems. I am talking here about the shoulder motion, which is dependent upon the acromioclavicular and SJ and SC joints. There is also the scapulothoracic articulation. This little two pictures does show actually the muscles that I spoke about, and on the right side we can see that the supraspinatus, and it's actually above the scapular spine. Infraspinatus is below the spine, and this is when we are looking from the posterior aspect of the shoulder. Also, the teres minor is below the infraspinatus, and if we look at the other picture, and this is from the front, we can see actually the subscapularis muscle, which actually cover the anterior section of the scapula. Now, the main topic is how to evaluate a patient, adult patient with shoulder complaints or problems. So I'm going to speak, more in detail about the clinical aspect, the practical aspect, rather than the academic aspect. First thing, we need to take a full history about when the pain started. Was it sharp, acute pain, or was it gradual pain? How long this pain was for? We need to know as well what factors that aggravate the pain or relieve the pain. The quality of the pain, which is this pain associated with the paresthesia or numbness, kind of nociceptive kind of pain, dull ache pain? We need to know what it is exactly. Location, and this is, I'm talking about, is it anterior shoulder, is it posterior shoulder, is it diffuse, vague description for the pain problems? All this will give us some guidance about what is the shoulder pain and why it's coming. Also, we need to know about the radiation. Of course, we have so many factors that can cause shoulder pain. Is it limited to the shoulder or going to the anterior chest or the upper arm? And all of this will help us. Then we need to look at the activities that exacerbate the symptoms, either at work, like such as lifting overhead or painting, or leisure, because some patients actually can get shoulder pain after, going to the gym. Sometimes swimming can aggravate it. So this actually helps us significantly to know why is this happening. We need to ask as well about previous injuries and treatments. Many patients might have surgery in the past, such as rotator cuff arthroscopic repair or washout of the shoulder, as well the comorbidities such as especially diabetes, and this is because there is an increased risk of adhesive capsulitis and peripheral neuropathy in diabetic patients. Then we need to speak a little bit about the pain location, because when we know the location, we can actually specify why this pain happening and where is it coming from. So I'm going to classify the location of shoulder pain to anterolateral shoulder pain and posterior shoulder pain. So the anterolateral pain, it's usually pain aggravated by reaching overhead, which is a common pain pattern. It is often associated with impingement syndrome, rotator cuff injury, and the various stages of rotator cuff tendinopathy. Also, there is adhesive shoulder pain, and we talk here about frozen shoulder, which sometimes or most of the times does happen in elderly population. There is as well osteoarthritis of the acromioclavicular joint, which is most likely the diagnosis when the pain is accompanied by stiffness and suspected with when pain is well localized. So actually in osteoarthritic pain, the patient can point his finger to a specific place. It's not vague, it's not diffuse, and this will help us. Involvement of the glenohumeral joint is suspected when pain is aggravated by movement in multiple directions. And here I'm talking about passive and positive or active shoulder movements. Now, after taking full history about the patient, of course, usually we do full neurological examination as part of the assessment of the shoulder pain. And when we talk about full neurological examination, it is a sensory, so we need to find out if there is any paresthesia, hyperthesia, allodynia, and if there is increased sensitivity to temperature. We need to do motor testing as well, and this is, of course, all the myotomes of the cervical nerve roots, starting from C5 to 6 to 7, 8, and T1. So this is part of the shoulder pain examination, and this is what I'm doing always in the clinic. So we need to do sensory, motor, reflexes, and lastly, in the shoulder, there are actually special shoulder tests. And this is definitely to diagnose impingement syndromes. There are a numerous number of tests, but here I just added, which is the most tests that I use in my practice, which is a Hawkins-Kennedy test, and it is the picture on the left-hand side when you flex the elbow and anterior flex the shoulder. We need to fix the shoulder by one hand, then we do internal rotation and external to see if this will actually, internal rotation will cause aggravation of the pain. The test on the left-hand side called NEIRS test, very simple, forward flexion, and we can divide this into 3 different categories. If the impingement is simple or minimum, so the test can be positive at 45 degree, then we have 60 degree, and then we have 90 degree. So it's 3 different parts, and the pain can be provoked when we do these tests. Regarding posterior shoulder pain, it is actually the least common pattern of intrinsic conditions affecting the shoulder and rotator cuff tendinopathy. Most diffuse pain over the general area of the superior trapezius can be referred from the cervical spine or cervical cause. So when the pain is diffuse, we expect that it's coming from the neck. Could be cervical strain or radiculopathy. And of course, radiculopathy and affect the shoulder, we are talking mainly about C4, C5, and maximum C6 myotomes or dermatomes. Poorly localized pain that is vaguely described is often extrinsic. Now, regarding the cervical nerve root impingement, it can produce sharp pain radiating from the neck into the posterior aspect of shoulder area and arm. Shoulder pain can be referred as well from the neck or the abdomen, and it results from compression neuropathy that arises from the bone. Gallbladder or acute coronary syndromes are other factors or causes in the differential diagnosis of shoulder pain problems. Now, I will touch base regarding the extrinsic causes of shoulder pain. It's divided into 4 categories. Could be neurogenic, as I mentioned, it's C5 and 6, radiculopathy, suprascapular nerve or brachial plexus compression, or could be herpes zoster. Of course, the list is huge, but I just picked up the most common causes of a neurogenic origin of shoulder pain. Regarding the abdomen as a source of the pain, it could be hepatobiliary syndrome and a diaphragmatic irritation. We see this very commonly after having laparoscopic surgery, when the patient, after recovering from anesthesia, can complain of shoulder pain problems. Cardiovascular reasons of shoulder pain could be axillary vein thrombosis, thoracic outlet syndrome, and acute coronary syndrome. In terms of the thoracic causes, it could be upper lobe pneumonia and apical lung tumor, in addition to pulmonary embolism. Now, we will move to the most important part of this lecture, which is a diagnostic approach of shoulder pain. Step one, we need, it could be actually traumatic versus non-traumatic. And this is the first question that we need to ask when they see the patient in the clinic. That's why actually history is very important. Trauma could come from clavicle, humeral fractures, and dislocations, most common. Step two, we need to ask ourselves about if it is extrinsic versus intrinsic cause of these shoulder pain problems. Step three, it's a glenohumeral versus extra-glenohumeral cause. Generally, the patient is able to localize the pain from the extra-glenohumeral pathology to a specific site, such as bicipital groove. And when I talk about this, I'm talking about bicipital tendinitis, could be bursa, and we have, as we know, a big number of bursitis that can happen in the shoulder. And tendinopathy, as I mentioned, it could be as well acromioclavicular joint or osteoarthritis. Step four, differentiating glenohumeral pathology. And this is, I'm talking about, there is impingement syndrome and rotator cuff tendinopathy. Positive impingement tests that I mentioned, Hawkins test and NEIR test, these are really, really helpful in the clinic when we test and to exclude this as a cause of shoulder pain. Cuff tendon tear as well, and during examination, I didn't go in detail during the examination, but I test in the clinic all the four muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. There are 4 tests. Each muscle has a test. So usually when there is a rotator cuff tear, there will be weak supraspinatus muscle. In adhesive capsulitis, like patients usually have actually diabetes, also there will be limited range of movement in all directions, active and passive. Glenohumeral osteoarthritis, the X-ray is very good to show, but it's not always actually a conclusive to tell us about this problem. So we have X-ray and we have a limited passive movements as well. I do very simple test. If I'm suspecting acromioclavicular osteoarthritis, I ask the patient always to reach the adult shoulder like this with the hand. If they cannot do this movement, I expect that they have acromioclavicular osteoarthritis. Now, what about the diagnostic imaging and tests? This is very important questions because there is no point to send patient for any test except if this test will change the clinical decision and scenario. There is no need to, send the patient in a dilemma and going here and there if this is not going to help me in treating this patient. So we need to really be reasonable when we ask for tests. Now, regarding plain X-rays, it can, of course, diagnose fractures, dislocations, and osteoarthritis. It has, in fact, limited benefit in the evaluation of non-traumatic shoulder pain. This was illustrated in a study, and this included 312 patients seen in an emergency department setting for shoulder pain. Only 37 patients out of 185 shoulder films, which is 20%, were therapeutically informative, and I have the reference for this study. A subsequent study of 206 patients used the presence or absence of the following features: history of falling, swelling, rest movement abnormalities in range of motion, and obvious deformities. The shoulder to help identify those in whom a shoulder radiography was unlikely to be informative. So from these two studies, and it's included a big number of patients, X-ray is not usually very informative. MRI can diagnose very well rotator cuff injury. Regarding the ultrasound, we need actually not normal ultrasound, we need a musculoskeletal ultrasound. Not all radiologists can give us this specific diagnosis. Hence, in many aspects and most of the time, I take the patients myself to the injection suite, and I do perform the ultrasound shoulder myself, and I can see if there is any tendinitis or bursitis to help me. The rotator cuff tears and bicipital tendon or tendinopathy, this can be seen. The tears can be seen, the bursa and the effusion can be seen. Normal tests include ESR, CRP, rheumatoid factor, anti-CCP antibodies, and all of these tests in case the shoulder pain is part of the generalized arthritic pain problems in the body. Now, moving to the treatment process, we have two types of shoulder pain, acute and chronic. Of course, pain physicians usually see chronic pain patients rather than acute pain patients, but maybe the acute one will be helpful for patients who present to the GPs or non-specialists. And most of the time, rheumatologists can help with this as well. The treatment for acute pain is very simple: rest to avoid movement, a short course of NSAIDs, and this is usually 7 to 10 days. Unfortunately, I have seen patients on NSAIDs for years for arthritic pain problems. Doesn't give any benefit. Maximum 10 days treatment. If it doesn't help, it should be stopped. Also, cryotherapy to decrease the inflammation around the area. Adjunct therapy, there is no high quality evidence exists regarding electrical stimulation or ultrasound treatment for shoulder pain problems. Physiotherapy, this is in fact a range of motion which is passive and active, stretching, strengthening exercises of the muscles around the shoulder. Regarding the subacute treatment, which is the actually pain not responding to a treatment, 2 to 3 months, and here it's classified as subacute shoulder pain problems. In this way, we can say that no improvement. There is clear evidence that benefit is lacking for subacromial steroid injection for rotator cuff tendinopathy. There is one systemic review done, and it's found only a small benefit from injection at 4 weeks compared with placebo. And there is no benefit at all for NSAIDs. There is another study published, and it's one double-blinded randomized trial, and it found again no difference in function or symptoms in patients injected with betamethasone and lidocaine compared to those who injected with lidocaine only. And this is in fact suggests that glucocorticoids provide no additional benefit to patients who present with rotator cuff tear or injury. Another systemic review assessing the value of physiotherapy and the treatment of shoulder pain found some evidence to suggest that steroids injection may provide a greater benefit compared with physiotherapy alone. Of course, we don't move to a steroid injection except if the physiotherapy and conservative management fail to treat. And hence, I strongly recommend to combine 2 things or 3 things at a time, so we can actually add injection at this stage. There is as well topical triglyceride nitrate, and in fact, GTN, there is one randomized double-blinded controlled placebo study of 553 patients with a clinical or MRI diagnosis of supraspinatus tendinopathy found significant improvement in symptoms for and rotator cuff function at 24 weeks. And of course, this is because the vasodilatation. Intra-articular injections, we can use steroids and hyaluronic acid. As you know now in the market, there is as well actually a plasma-rich platelet. So there are 3 stages here. We have steroids only, we have plasma-rich platelet, and we have plasma-rich platelet plus hyaluronic acid. So I take steps one by one and see which one will benefit the patients. This is used in adhesive capsulitis, osteoarthritis, rotator cuff tendinopathy. This treatment showed improvement in clinical outcome, both in terms of reduction of pain and increased mobility. In terms of ultrasound guidance, it is highly recommended to do all injections ultrasound guided, because the blind injection is associated with a high failure rate. This image actually shows the glenohumeral intra-articular injection posterior approach. We can see the needle, and we can see it's very nice and easy block if we use the ultrasound. Now I will touch base regarding evidence of treatment. Ultrasound guided long head of the biceps tendon injection. So actually this treatment is showing good benefit, and I have tried it myself on many occasions to treat bursitis or to treat tendinopathy, and I can see if it's ultrasound guided, this is good. Ultrasound guided selective nerve root, suprascapular nerve block, and this is, I'm talking about different parts or different treatments that can be offered interventionally for the shoulder. Suprascapular nerve is a mixed nerve, and it accounts for 70% of shoulder joint sensitivity, mainly innervating the posterior and shoulder capsules and superior capsules. Now, does the combining a suprascapular nerve block with intra-articular steroid injection have an additive effect in the treatment of adhesive capsulitis? This was a study, and this was done published in the Journal of Sport Medicine 2019, and it compared the functional outcome after short-term and minimum 1 year follow-up. So they found that both combined SSMB and intra-articular injection in one category, and intra-articular injection only in another category alone, significantly improved pain and functional outcome in patients with adhesive capsulitis. The use of a suprascapular nerve block with intra-articular injection further increased treatment efficacy. Here is a small diagram that is showing the position patient usually is sitting. I go usually in plane, and you can see we can go to the area where the suprascapular nerve locate, and we can do this very easily, risk-free. Quickly, I will touch base about neuromodulation in shoulder pain treatment. We have two types of neuromodulation. Either talking about the fully implantable peripheral nerve stimulation for hemiplegic shoulder pain problems. And this is a study that was done, multi-site center case series with 2-year follow-up. And this was published in 2018 in the Neuromodulation Journal. 28 patients underwent trial stimulation, and the participants received an implantable pulse generator, which is the axillary nerve. As we know, shoulder innervation is coming from two areas, suprascapular nerve and axillary nerve. All 5 participants who had the implant experienced 50% of greater pain reduction at 6 and 12 months, and 4 experienced at least 50% reduction at 24 months. Hemiplegic shoulder pain problem is one of the most difficult pain problems to treat, and that's why I did put it in this slides. Regarding the ultrasound-guided suprascapular pulsed radiofrequency treatment for chronic shoulder pain, this was a study published in Medical Ultrasound Journal 2018. 74 participants diagnosed with at least one of the following: adhesive capsulitis, rotator cuff syndrome, and impingement syndrome of the shoulder. Yeah, almost there. The PRF therapy of the suprascapular nerve under ultrasound performed in those patients with a reduction 50% or more had actually significant reduction in the visual analog score and recorded healing in active range of Thank you very much for listening to me, and I hope you enjoyed the lecture. I can't actually listen. I can't hear Tolu.
Can you hear me now?
Yeah, now, yes.
Fantastic. Dr. Mubarak, that is an absolute excellent presentation.
Thank you.
Very good overview. You literally covered everything so well. That is amazing. I say very big congratulations to you.
Thanks very much.
Unfortunately, we don't have so much time for us to take us into more details about, shoulder pain and all the other form of modalities of treatment, but you've done absolutely very well. Now, we have a few questions from you. Before I start with the question, I just want to welcome some friends I see in the list of the attendees. Professor Akano from Nigeria, that is amazing. Professor Four, Dr. Four as well, that is great. Thank you, you're welcome. Now, the first question is, from your experience, what is the benefit of doing a PRP injection versus a corticosteroid injection? Which one do you think is more beneficial for the patient? And which one will you choose, when you treat your patients?
Sure. So it depends really on the pathology or what is the stage of the shoulder pain problems. The simplest stuff is to start with the steroid injection. It's actually less expensive compared to the PRP treatment, and I know exactly what is the cost. So I offer usually the patient the steroid, but most of these patients already had a lot of steroids done in the GP practice. They do it blindly, and they are doing it every 3 months already. So when they come to the pain clinic, I found the PRP is really helpful for patients with arthritis. And even I go further than, because now the company has they have some some preparations where there is mix between PRP and hyaluronic acid in the same tube. So it depends. If the patient, of course, it's all cost as we mentioned. We start with PRP first. If it doesn't, usually actually give very good benefit, a year benefit. But if it doesn't show improvement, I mix with the hyaluronic acid, and this will be the next shot of treatment.
Fantastic. Thank you, Dr. Mona. Now, the second question for you. There's a Dr. Mohammed in the audience. He was asking something. What about doing a supraglenoid suprascapular nerve block compared to a proximal division? Which one do you think give more benefit for the patients?
So the higher we go in the injection, the more we can cover. The problem, if you go at the lower level, you might skip the supraspinatus muscle. And, this is not recommended. The higher we go, the better. So I prefer the proximal, because actually this will give me a chance to cover everything that I need. And everything, it's a trial and error. We try. And of course, the anatomy, how to see, under ultrasound, if there is something on my way or not. So all of this, it's a clinical decision. But I always prefer to go actually higher. And even though in some situations, I go actually to the trunk, I go to the, brachial plexus, C5-6 area, and get the suprascapular nerve from higher position if the patient had previous surgery and I can't see anything, and it still work. So that's the situation.
Very good. Thank you, Dr. Mona. I'm just going to chip in there a little bit. You mentioned from the start of your presentation that your suprascapular nerve supplies both your supraspinosus and the infraspinosus branch as well. The motor branches take off very early. So the chances are that if you block it more proximal, is there a likelihood that you get both a sensory and a motor block? And how long does the patient suffer that weakness for?
Yeah, so in fact, in my experience, I didn't see anyone who had weakness for a simple reason. I always make the local anesthetic very diluted.
Excellent, excellent. Great, Dr. Mona.
That's the trick. So it's 0.25 or even 0.125%. We are looking at the steroid benefit rather than the local anesthetic benefit.
True. Fantastic. Now, there's another question by one Dr. Mohammed there. Dr. Mohammed was asking, and part of the question I wanted to ask you as well, Dr. Mona, Is there a place for pulse radiofrequency ablation for some of the branches of the nerve that supply the shoulder? Like in my center, I do a lot of pulse RF. Like normally there are three main nerves. Sorry.
The
There's
sound
too
is
much noise at the background.
yeah.
No, okay. I kind of target the lateral pectoral nerve, the axillary branch, and the suprascapular branch. Now, positioning the needle could be very tricky, but one of the audience is asking, is there any benefit for a pulse RF in the management of shoulder pain?
There are a lot of studies and publications that showing that PRF treatment is much better and beneficial compared to just normal injection. But I never do ablation actually. I never hit the nerve to the 80 degree that, you know, the normal ablation, because here, this is a mixed sensory and, you know, motor nerve. Mm-hmm. So I never did ablation before. I only do PRF treatment 42 degrees, and this is usually enough.
Oh, no, I totally agree with you. Just to clarify that, I'm talking about doing a pulse RF. Nobody does a conventional RF on motor nerves. You don't do that. Yes. But a pulse RF definitely will give you more relief. Now, one question I have for you, Dr. Mona.
Yes, Dr. Tulu.
You said something very important there. That in managing some of those patients, locating the pain is very vital.
Exactly.
There are some categories of patients that have very bad osteoarthritis or having very bad psoriatic arthropathies affecting their shoulder joint. Mm-hmm. And they are not recommended for surgery. Mm-hmm. How do we help such categories of patients come into our clinics? Then aside from these, what about those sportsmen that keep suffering with recurring shoulder dislocations? Yeah. What hope can we do for those people? And finally, those patients with Ehlers-Danlos syndrome, connective tissue disorders that keep suffering from recurring dislocation of their shoulder, how do we help them with their pain control?
Okay, this is actually 3 questions, Dr. Tulu.
Yes, thank you.
Yes, you are very clever. Okay, that's what I used to know about you when we worked together in Dublin. You're asking 100 questions in one time. Okay, so first one, talking about I believe you said adhesive, severe psoriatic arthritis, right?
Yeah.
Yeah, so psoriatic arthritis, it's part of the generalized arthritic problem in the whole body. As we treat the cause before the symptom, in my view. So we need to optimize the psoriasis through our colleagues in rheumatology, maybe immunosuppressants, maybe something, but anyway, to optimize. If the psoriatic arthritis in the shoulder is part of the generalized arthritis, usually I don't do local injections. Because how many you will inject, the knee or the shoulder or whatever? So many. So we need to improve the general condition of the patient, I think.
Perfect. Okay. While we are waiting for Professor Margarita to come, I think I'll just throw some questions to Dr. Mona. Few of the questions. Somebody here just asked a very straightforward, simple question. He was asking, in what position do you put your ultrasound probe for your shoulder injection?
Okay, so as I showed in the images or the pictures, usually patient is sitting, and I put I can define the spine, the scapular spine, and usually I put the ultrasound, probe parallel to the scapular spine. It's very clear to see that one, and then I move from inside to outside until I see the notch, the suprascapular notch. Perfect. And usually I go in plane.
Okay. I have another question for you here. And somebody was just asking here, if a patient that has a chronic shoulder pain is going for an acute surgery, is going for a shoulder replacement, what are the treatment modalities in terms of pain control? What options do you have for those patients, Dr. Mona?
Okay, so usually when the patient go for shoulder replacement surgery, usually they are at the end stage of shoulder arthritis or frozen shoulder, and usually they have significant amount of pain and functional disability in that area. So we do need really to prepare these patients by having some, in my opinion, some anti-neuropathic agents before we proceed to the surgery to control the post-operative pain that is coming. So it's really advisable as well to have some regional anesthesia on top of the general anesthetic. So brachial plexus catheter for 24 hours. Yeah.
Perfect. Thank you, Dr. Mona. That is excellent. Thank you so much for your time. We really had a good time listening to your presentation.
Thank you. Thank you.
We hope to welcome you back in the near future and to listen to you. On behalf of every member of the Mega Online Anesthesiology course and all the attendees, we say a very big thank you to Dr. Mona.